shall we go for the next speaker?
شكرا.
Thank you. And now the next speaker, Dr. Joanna Brown, our dear professor. Thank you for Dr. Dina for bringing such eminence, doctor. Dr. Joanna Brown is the president of World Federation of Pediatric Imaging. She's also a senior consultant for pediatric imaging in Bristol University, and she also is senior consultant in United Nations, IAEA, and WHO. And the topic will be about CT imaging. How can we make it right for children?
Dear Hanan, thank you so much for this very great invitation. And I just want to say good morning to everyone, and it's nice to be with you and share information and experience in pediatric CT imaging. And the next 10 minutes, I'm going to take you through the very short journey, how to make the pediatric imaging right. And you've probably seen these slides and the pictures several times because children are not as small adults. And we always need to remember when we image the little patients. They are not small adults because they are much smaller in size, but they also have a very different body structure, different body metabolism, dynamics, and they are very, very active. And all of this will influence what we are doing. They have a different body structure, the size of the coils in MRI, the size of the protocols, everything what we are doing in the imaging, which depends on the body. The body is growing and changing, and also they have a different proportion of the body with the greater size in the head, short neck, and the short limbs. And also, they have a different structure when you talk to the chemical components. So they have a very high water contents, which is 75% of the body mass at birth, when the adults have only 55 to 65%. So this information and this fact will really influence what sequences you are preparing and making in the MRI imaging. Then they have a different blood volume. In neonates, you have 85 milliliters per kilogram of the body weight, with adults is 60 to 70. So when you inject the contrast in CT or MRI, this should be taken under the consideration. And the total blood volume is 350 milliliters in neonates. So you need to adjust how much volume of the contrast you will be giving. Then the metabolism is also completely different. They have a higher pulse rate, blood flow, and the respiration day. Then they have more oxygen in the blood than adults. They have increased CO2 level, greater surface area to the weight ratio, and also much higher body temperature and immature thermoregulation. So you can't put the little neonate or the premature baby into MRI scanner for 30 or 40 minutes because we really don't know how the increased temperature will affect their body. And several challenges in looking and imaging the children. We have limited clinical history at examination, they can't stay still. We also have a normal variance characteristic for age, which is important when we are doing our tests. So limited history and examination, they present with the discomfort, they present with the pain and the cry, and how do we know which part of the body to image? The other challenges is that they are always very, very nervous and frightened, more than the adult patient when they are going to the hospital. And because they cry and difficult to keep still. So what we try to do to make the most friendly environment for them, how and when we image them. In the children's hospital, it's relatively easy because you have all of the nice colors, you have toys, you can see it here on the left side, how the MRI suite can be created. It's a little bit more difficult in the general hospital or the district hospital, but you can always put the stickers on your MRI machine, and even adult patients like it, or you can create the special corner, as you can see here on the picture, in your general department with toys, the corner dedicated to the patients. What we are really lucky in UK that we have a play specialist in our hospitals. So there are dedicated nurses and radiographers that they deal and they look after the little patients when they come for the scans. So very often before the CT or MRI, we will bring the patient into our department like an hour before. They play with the nurses who will explain everything about our test, and then children are much easier to tolerate the scan. So we play with them. We also can give the IV sedation if they are very nervous or they can't stay still. We can do the scan under general anesthetics, or we also would start introducing to scanning children in the evening, about 8, 9, 10 in the evening in the departments, because we try to make them really, really tired and then make them fall asleep, hopefully in our MRI scanner and in the table. And why do we worry about this? Because we all know that the children have a higher radiation sensitivity, they have a longer life expectancy, and they are more susceptible to the radiation damage. So we need to remember it. And you all know the slides, how the moral artery excess persevere when you will look into the different part of the body. And again, another graph published in Radiology showing you the cancer incidence. And you will see that giving radiation at the early stages, it's really, really difficult. And then estimated dose of the examination, and you can see it here, how it's increasing from the normal radiography into if we are going to the cross-sectional images as a CT. And again, from the CT head and the body with the millisieverts. And why am I showing you this? Because we all know that the examination that we perform in children is increasing approximately 10 to 20% per year. And this is only about the CT scanning. This is the data from US because they produce the most important accurate data. But we know that we are doing more than 10 million CT examinations per year, and about 30% pediatric scans are multi-phase. 2 months ago, we have the Asian Congress of Pediatric Radiology, and some of the radiologists from China share with us that for the CT, for the diagnosis of appendicitis, they do 3-phase CT examination because this is what they are doing. So why we are increasing the CT examination so much? Because it's very, very easily available. It's available day and night in our hospitals. CT radiographers that are always on call. We have a shortage of sonographers and shortage of radiologists with the pediatric training. So it's much easier to put the child through the CT in the middle of the night than organize the ultrasound or MRI. We have less experienced pediatricians who would like to have more and more scans, and also is a fear of litigation and complaints, and the doctors being taken to the court more and more. So if we remember all of these challenges, we also need to remember the doses that we are giving to our patient. So CT indications really in pediatric imaging are changing. In trauma, oncology, and congenital conditions, we are decreasing it. In headaches, acute abdomen, in chest infection, we stop doing CTs. We replace them with the MRIs and the ultrasound to reduce the radiation. And thankfully for us, we have several guidelines published by different colleges and the organization which will help us to choose the best examination. And a few examples from the guidelines that really X-rays are not indicated in the epilepsy, in headache, in sinus disease in children older than 5 years because they just don't have the sinuses yet. Or we don't do the X-ray of the opposite side. And again, the guidelines will help us with this. So with CT examination and any other examination in children, perform only necessary examination, use the referral guidelines for justification, and try to replace the CTs with other modalities and the ultrasound and MRI, and use the specific pediatric protocols with reduced number of multi-phase examination. And as Ola showed you during the previous lectures, there are a lot of information available on the website, on the AIA website, but also free publications, like this article about the pediatric abdominal CT and the diagnostic reference levels. And we always need to remember that we need to think about the radiation dose. And this is the examples of the CT with the reduction radiation dose. And yes, CT on the left side on the top is the best one and looks really, really pretty. But the CT on the right side is fully diagnostic, and you save a lot of up to 83% of the radiation dose. And again, nose via the reduction. So we need to optimize the scanning parameters, what we are doing with a tube current and volume coverage, and we have several publications that will help you with this. And the one thing that I wanted to stop for a minute is the dual energy CT that we are start having more and more often in our departments. And when this was introduced a few years ago, it was always query about the increasing dose, but now we have several multi-center studies showing the good outcome of using dual energy CT. And this is one of the recent publications in 2020, which shows the proper protocols established on this machine will give you the reducing radiation dose and reduce volume of the contrast that you will need it to do it in scanning children and young adults. And this is the table from the article. So in conclude, perform only necessary examination and use the referral guidelines and pediatric specific protocols. So this was a very short overview, a minute longer, so I'm sorry, just to give you, to make you think about imaging of our little patients. Thank you.
Thank you, Joanna. We'll take any questions at the end of the session. Our next speaker is Yusuf